Good evening. Welcome to the MyCP webinar. My name is Paul Gross, and I'll be your host this evening for a discussion of functional changes, pain, and aging with cerebral palsy.
And share real quick. Go.
I'm going to mute some people. Okay, and so I'm really excited to have Dr. Mary Gannotti and and can't believe I did that, Dr. Ed Hurvitz and Jodi Kreschmer to share their knowledge and experience with you. So I think it's going to be an exciting presentation. So we start these out with a quick presentation about the CP Research Network. This has changed a little bit. I've got an updated presentation. So I usually tell most of you that come a lot to tune out, but you should tune in. I think you'll find these additional pieces of information quite interesting. So we'll do a quick introduction, and then we will turn the mic over to our speakers, and then hopefully have plenty of time for a Q&A and discussion at the end. Okay, so the Cerebral Palsy Research Network was founded out of a NIH workshop that happened in late 2014. It was entitled The State of the Science and Treatment in Cerebral Palsy. And one of the key things that it emphasized was the need to establish a national registry for tracking and accelerating research, the need for comparative effectiveness research to compare interventions. And for those of you that are familiar, sorry, I'm getting ahead of myself. It looks like my screen's not painting as I expected. It also focused on the importance of the study of adults with CP and developing a research agenda for basic and translational research, and finally bringing more young investigators into the field. And then it also really emphasized the importance of closer connections between patients, families, and investigators. So one of the first things that we did was we put together a patient-centered research agenda that was funded by PCORI, went through a series of trainings and came together in Chicago in 2017 and came out with a paper subsequent to that that identified 16 key areas as prioritized by the community. And so this is the 45 of us gathered in Chicago back in hot summer June day in 2017. And we established our mission, which was to optimize the lifelong health and wellness of people with cerebral palsy and their families through high quality research, education, and community programming. So we have these 4 pillars of our work, our research and quality work, where we get together every year with a growing group of both investigators and community members. Our educational materials, both online as MyCP and our toolkits, our health and well-being programs right now, largely through a partnership with the National Center for Health, Physical Activity, and Disability. And then we do community engagement, such as the patient-centered research agenda we set, and we've done 2 of those. And then our webinars, where we share our research and open the floor up to you for discussion. So our vision is that by engaging you, a very broad community of stakeholders, as well as a vast number of the healthcare systems that treat people with CP, if we can engage them in a learning health network, and that's a buzzword that means using the data that is generated from the care of people with CP to improve the care. And so we believe what we can do is collectively focus our research on that care about the issues that matter to you most, since you have played a significant role in creating what that agenda is. And so we will gather and share lived experiences of community members, and we'll measure the healthcare system to see if it's improving your health and well-being. So that's the vision of what we're driving towards. We've had a lot of key milestones in our education with the launching of our CP toolkit back in 2015, our web personalization and MyCP, and these monthly webinars, which have been going for several years now. On the research front, we accomplished that first goal out of that national meeting. We launched a CP registry that now has more than 10,000 patients in it, which is really enabling us to do a lot more research and secondary analyses and planning. And then we have a community registry with a couple thousand people in it as well. We have our research agenda, which I've talked about. We've gone on to get funding from NIH, and we've partnered with the largest private funder of CP research. That's the CP Alliance Research Foundation. We do quality improvement as well as research. Quality improvement is just another way to improve outcomes, but gets faster results. And then we're very academically focused with publications. Had 13 publications, 39 academic presentations, and we've got a lot of manuscripts that are under development. And we're starting to do secondary analyses of this very large registry, which means we can take the data that's collected and find new things by analyzing that data. So that's very exciting. And then I talked a little bit about our wellness programs and that we've been working with NICPAD on. So I want to talk briefly about a registry. A registry is a database. It collects different data points on people with a given condition. Our registry is focused on CP. Here's some data on the left using the gross motor function classification system, which is a 5-level scale describing how people move about the community. And you can see the distribution of people that are in our registry. And then you can see the age distribution. You can see that, a significant portion of the people, like 26% of the people in the registry are adults. But in reality, there are more adults in the US with CP than there are children. So if you look at our community registry, and look at it at the same two scales, you'll see the distributions look different. And this reflects the bias of what we can find based on people selecting to come into a clinic versus people selecting to fill out surveys online. And so it leans a little bit more towards gross motor function classification system 2, but it's also got a lot more adults in it. So you see 60% of the people in the adult registry are adults. I'm sorry, 60% of the people in the community registry are adults. So we are a 32-center learning health network spread across North America. The green pins are sites that are collecting data into the registry. The yellow pins are working on the technology. The blue pins are sites that have raised their hand. The red pin is still working on getting the agreement done. And all the green circles are sites that are lifespan centers. So they're treating both kids and adults with CP. So we exist to stimulate the research ecosystem and really let 1,000 flowers bloom. So I want to describe aspects of this and just give you an idea of how effective this has been. So we set a patient-centered agenda, research agenda. We build infrastructure to help investigators. We try to balance between both creating evidence, answering questions, and just improving care through QI. And we use the registry to monitor the implementation and outcomes. So this is our study pipeline that's empty. It's like just conceptually, we try to get people in the network to generate concepts. We review them. We go for funding. If they're funded, we execute the studies, and then we write up the results. We get those published, and we try to take the findings and roll them back into the way care is done. I'm going to play an animation now that's going to show you how this pipeline has been filled since we started. So it's going to take about 10 seconds, and I'm going to start it now. So you can see what's happened over time is we created this infrastructure, and then slowly but surely it built, and now it has a ton of momentum and is generating a ton of research. So those are the unique values of the CP Research Network. It provides this sustained platform for research and quality. It enables us to study long-term outcomes, and it implements a national learning health network for cerebral palsy. And so with that, I'm really excited to turn it over to our speakers. Dr. Gannotti is a professor of PT at University of Hartford and involved in so much of the network's work and moving it forward. Dr. Hurvitz is the professor and past chair of the Physical Medicine and Rehabilitation Department at the University of Michigan, and also is a leader in our network on many fronts. And Jodi Kreschmer is a research specialist at the University of Michigan contributes as a co-producer to some of our research and is also a member of the community. So I want to turn it over now to the team to present.
Thank you, Paul. As Paul said, I'm Jodi Kreschmer. I'll be starting the presentation. Dr. Gannotti, can you pull it up, please?
Slides, definitely.
Thank you.
Just give me 1 second. Wow. I am so sorry, Paul.
What's up?
I am just having this problem to share my screen. Okay, share screen.
I'm sure we'll get there.
We'll
Everybody's forgiving with this crowd.
We'll get there. We're fine. Right? I'm going to share this screen. And then I slideshow. And I'm going to do it from the beginning. And, okay, escape. Share. And I'm going to slideshow from the beginning. Can you see the slide?
Mm-hmm.
Yes, we can.
Excellent. Okay, Jodi, take it away.
Okay. As Paul said, our presentation is going to be about functional changes in pain with aging and cerebral palsy. I wanted to introduce myself a little bit more. I'm Jodi Kreschmer. I'm a person with cerebral palsy, and I'm a clinical research coordinator at the University of Michigan. I have done a variety of different studies, mainly looking at women's health issues for women with physical disabilities. I've also done research in cerebral palsy, specifically surrounding kidney health of people with cerebral palsy, and I'm currently working on a project that's looking at making self-driving cars more accessible for people with disabilities, and I'm also helping Dr. Gannotti and Dr. Hurvitz with the Cerebral Palsy Network to look at pain classification for people with cerebral palsy. I work with Dr. Hurvitz, who, like Paul said, was the past chair at U of M, and I also work with Dr. Gannotti. You can go next slide. Today we are going to focus on functional changes in pain. Our objectives for this study is to identify the reasons why adults with cerebral palsy may experience functional changes in pain with aging. We will describe how common these changes are among other adults with cerebral palsy. We will also identify ways to reduce the impact of pain and functional decline. And Paul really took my last part when he was just talking about the network and what it does. But at the end, I'm gonna tell you a little bit about why it's important to be a part of research and how exciting and fun it is. So yay, research! You can go to the next slide, please. Once again, this is just kind of our outline for this evening. I am first going to talk about some questions myself, other research participants I'm talking to, and just friends and colleagues have about growing older as an adult with cerebral palsy. Dr. Hurvitz will then explain why there is a functional decline and pain for some people. Then Dr. Gannotti will talk about the adult surveys on function and pain, and at the end, I will be promoting participation in these surveys because they're super interesting. Dr. Gannotti will also be talking about pain types and treatments. And again, I probably won't be talking about why I hate to join UCP that much because Paul did an excellent job. but I will talk a little bit about experiences participants I've talked to had and why it's important to complete the surveys on the website. You can go to the next page. So I would say, almost middle-aged person with cerebral palsy, and in the past year or two is when I have seen my function decline. I used to walk with the walker all the time my whole life. When COVID hit, that kind of went away a little bit. So I can still walk a little bit around my house, help with my personal care assistance, that kind of stuff. But usually in the community now, I'm either using a wheelchair or a trusty scooter to give me more independence for myself. So during this period of change, I really thought about these questions. And like I said, people I know have too. So today what we cover how your abilities might change, where is my pain from, doesn't matter what type of pain I have, and how can I manage it. These are the key questions that I've always think about these past couple months, and the people at the CP Research Network have helped me understand this a little bit better, and so I hope this can help other people too that are going through these changes.
Okay, thank you, Jodi. Well, I want to talk about how might your abilities change as you age. Why is there functional decline and pain? And I should start off by saying there's a lot of reasons. We don't know the exact reason for every person. I'm going to review some of the things that we feel are factors that cause people to lose function and to have pain. Next slide, please. So the first thing is there's great news about lifespan with cerebral palsy. Folks that are in the GMFCS 1 and 2 categories, the higher mobility functioning, have excellent survival. 98.2% have a regular lifespan, and that's great news, much better than it was years ago. And even more exciting is that for folks that are, quote, less mobile, the GMFCS 4 and 5, there's an increasing average lifespan, and that's great news. There's over 500,000 adults with CP in the US. I recently saw something about 700,000, so I may have to update that slide. Next slide, please. So when a person has cerebral palsy, their whole development, their physical, anatomical, their whole body development is changed because of the cerebral palsy. We all know the cerebral palsy is caused by a problem in the brain in the infant, but that problem will cause problems with how the bones are developed, how the muscles are developed and function, and how the joints work. Next slide, please. So looking at muscles, people with cerebral palsy tend to have low fitness. They tend to have obesity. On the left is a graph of a slide we did several years ago. It's children. This is for children with cerebral palsy that were ambulatory, that could walk, GMFCS 1 and 2. And we see that over there on the far left side, there is a bit of a rise in the bars, which is people that are underweight, which is what we often see in cerebral palsy because of a low muscle mass. But then on the right, there is large bars that show people that are considered to be overweight and obese. So we see that about a third of the children were scored as overweight and obese. Now, the thing about that is it's really higher than it looks because people with cerebral palsy have less muscle mass and less fat and less bone mass. So they may have lower weight with the same fat mass, the same amount of fat, and they still have, a more normal BMI. So the truth is there may be more people with cerebral palsy that should go into the obese and overweight category. The picture on the right shows the difference in muscles between people with cerebral palsy and people who don't. The top three are a person with cerebral palsy with various layers of fat removed to get down to the muscle. And we see in the last picture, there's still a lot of fat in that muscle, within the muscle itself. And we don't see that pattern in the person without cerebral palsy in the graph below. So we see there's a lot of fat in the muscle in cerebral palsy that makes the muscles less efficient, not work as well, contributes to low fitness, and is as a result of some of the obesity. The obesity causes the problem, and then it further causes the obesity by people being less active. Next slide, please. Joints can be a cause of pain, and that pain in the joints can cause decreased function. So people with cerebral palsy often have hip dislocation. That joint comes out of place, and that really interferes with their ability to function. They may have pain in their joints from using assistive devices because they're using their arms more than the arms were designed to help support our weight for walking. And then there may be contractures of the joints, which lead to joint pain and, of course, can contribute to loss of function. Next slide, please. So with all those things, with the way the muscles are not working as well and how the joints are changed, walking is affected. So for example, tight hamstrings will lead to strain on the back as the person walks, will cause an increase in lordosis. On that picture on the right, you see the person there with the spine, and the low back curve is called lordosis. We all have that, but if that is higher, if it's more than it should be, that can cause back pain. And it's often more than it should be because the hamstrings don't get enough stretching, as is demonstrated in the other picture in the top, where you see some good stretching going on. Hamstrings don't stretch. It pulls the weight on the pelvis, and that causes the back to curve. That leads to back pain, and pain will decrease function. In addition, the spasticity and contractures will change the walking pattern, so it doesn't work the way the joints were really designed to work, and that again causes pain and decreased function. Next slide, please. So spasticity. What happens to spasticity as people get older? Well, some people say it's better, some people say it's worse, some people say it's the same. But the thing is that spasticity can definitely increase for a variety of reasons. And when the spasticity increases, there's more changes in the gait and the walking and more stress on the joints. There can be a lot of reasons for this spasticity to increase, including some neurologic causes. There can be a problem with the spine we call spinal stenosis, which is pressing on the spinal cord and causing more spasticity. Or sometimes people with cerebral palsy have a stroke that's not detected because it may affect their cerebral palsy side, and they just think their cerebral palsy is getting worse, but that's causing increased spasticity. Certainly lack of stretching, and then lack of treatment. A lot of people with cerebral palsy don't see the right doctors, the right specialists who can give them that kind of spasticity attention and treatment that they got when they were children. So spasticity can go up, and that can cause even more of the problems that we've been talking about. Next slide, please. People with cerebral palsy are a significant risk for fractures, and a lot of that can come from falls. So we see the two colored graphs, one for female and one for male. The dark black line, focusing on the female graph, you see that the dark black line is people with cerebral palsy. And the light line, the gray line, is people without cerebral palsy. And you see that in women, the amount of fractures all through the lifespan is higher in people with cerebral palsy than it is people without cerebral palsy. In men, we were very surprised to find out that their picture looks very much like the women. Now, we all know that women have a higher risk of fracture when they get past menopause. But the men don't have that kind of change, and that's reflected in the line of men who don't have cerebral palsy. But the men who do have cerebral palsy, their line goes way up. And this has a lot to do with the fact that right from childhood, the bones are not formed normally. They don't have all the structural integrity that people who don't have cerebral palsy have in their bones. So if you combine that with the fact that people with cerebral palsy often fall much more often than people who don't have cerebral palsy, you see fractures. There's a picture there of an arm and a cast. That's a pretty common fracture for people who fall, try to catch themselves on their arms. The bones aren't strong enough and they break. Next slide, please. There can be problems with nerve impingement, what we call a pinched nerve. This can happen in the back. I talked about the spinal stenosis pushing on the nerves. It can happen in the neck, same kind of thing. Nerves can be caught in a contracture, that picture you see with the arm with that red area where that contracture is pinching the nerve that goes through the arm into the hand. And then we talked about how using a walker or assistive device can be stressful on the joints. It can also cause some compression on the nerves. I'm sure most people have heard about carpal tunnel, which is a trapped nerve in the wrist. And that can occur when you're using a walker or putting pressure on it too much, a cane, that kind of thing. So these are other causes of pain, and then some decreased function because the pain causes decreased function. And then these nerve problems can also cause muscle weakness, again, contributing to decreased function. Next slide, please. People with cerebral palsy are at higher risk of chronic disease. The graph that shows the nice blue and yellow colors, those are the U of M colors, shows people with cerebral palsy in blue and people without cerebral palsy in yellow. And for all of these chronic diseases, in the study that we did, where we looked at thousands and thousands of people with cerebral palsy and without cerebral palsy, we saw that these diseases had a higher prevalence. That means they were more common in people with cerebral palsy than people without. They included diabetes, asthma, hypertension, heart problems, stroke, emphysema, joint pain, arthritis, all these things. We didn't even look at things like kidney disease, certain inflammation problems caused by obesity that we found later also are higher. People with chronic diseases don't function as well, don't feel as well, and can be subject to pain because they're not moving around as much, and other problems that can contribute to the pain syndrome. Next slide, please. Bowel problems are very common in people with cerebral palsy, adults with cerebral palsy. We did a study, the graph is shown there on the bottom picture, and it looks at people with symptoms of constipation. There are some studies that showed 1/3 of a community population complaining of bowel issues. In our study, more than half had some symptoms. Irritable bowel syndrome is very common in cerebral palsy, unfortunately, because of all the, I don't know exactly why, but I suspect it's because of all the problems with the bowel moving, the bowel motility, we call it, with the bowel's ability to move the stool through and out, can lead to distress on the bowel and probably causes irritable bowel syndrome. Also, some people with cerebral palsy have difficulty with getting proper nutrition, be it because they can't swallow well, or be it because they don't have the resources to get that nutrition, perhaps don't have the fiber that they should have. And then some people with cerebral palsy don't drink enough because they're out in public and they know it's going to be a problem accessing the public bathroom. So they don't drink, and all that can cause constipation as well. And they don't move around as much. So all of these are contributory problems. Next slide, please. Fatigue, sleep, and depression are all common complaints in adults with cerebral palsy. All three of these things contribute to pain. People that don't get enough sleep tend to have chronic pain problems. Depression is seen to contribute to the sense of pain. Things that might not hurt as much to other people may hurt more if you have depression. And then fatigue, sleep, and depression are made worse by pain. So it's a cycle that is very problematic for adults with cerebral palsy. Next slide, please. Now, here's something interesting that is some research that's coming out now, and that is that when babies are in the neonatal intensive care unit, we call the NICU, they have a lot of procedures, and those procedures are painful for the baby. That seems to do something to the baby's sensory for pain, how they sense pain later in life. Now, some of the studies I saw look at the children when they're 5 or 6 years old, but there's every reason to think that that may go on into the adult years and then cause some difficulties that they have with their pain sensing system, which makes them more susceptible to having chronic pain. An interesting problem. We don't know all the facts yet, but it's something that we want to look at. Next slide, please. The thing about pain is that studies show that it's the main predictor of quality of life. People who have pain report a lower quality of life. However, pain is part of life. In cerebral palsy, we're publishing a study soon that will show that about 90% of people with cerebral palsy have one or more pain complaints on their medical record. Studies do show that the main difference in quality of life is due to pain. Pain treatment is complex in cerebral palsy for many reasons. Access to medical care, ableism of the medical care system, resources to get the therapies that they need, accessibility of getting some of the treatments. So we need a greater understanding of pain and how it affects function. This will help us to develop a better treatment. Next slide.
Great.
Can everybody hear me now?
Yes, we
We're
can.
good? All right, excellent. All right, so one of the questions that people had in the research CP was, how might my abilities change? What could I do to prevent this? And what can I do to mitigate it now? And we're really excited about the clinical registry that is happening amongst CPRN, but also we wanted to collect information from people in the community. And patient-reported registries can give us information and insight that we may or may not get in the clinical registry. And it also will give us information that we don't get from the insurance database as well. So as we talked about, we have this internet presence for a broad community. And what we have created is when people enroll into MyCP, you provide some clinical information, some information about your age and your distribution of cerebral palsy, and then you're offered to do some surveys. And we have 2 surveys that collect information about changes with function with aging, one about overall well-being, and then another one about the stigma that you might perceive that you encounter in everyday life. And then if you have chronic pain, there is a series of questionnaires that ask about your pain location, its intensity, and some of those things that Ed talked about, like anxiety and depression. And also if you use, what kind of treatments you use, and if you've used opioids. So our recruitment has been passive. We have not paid participants. We've just used social media and blogs. Jodi is one of our people who's helping us contact people in the clinic, also to provide them with flyers. We've been working with other organizations like Cerebral Palsy Foundation also, and we've been doing these webinars. We had our first set of publications this spring with our initial set, and our data set has now doubled to over 500. But in this analysis, we have about 260, and you can see we're very much overrepresented with people that walk and can use their hands and communicate really well. And we don't have a lot of wheelchair users or people that requires a lot of assistance with their hands. And we've gotten feedback from community members that we might need to use some sort of adaptive interfaces to promote that for people with different abilities. And I think that's really awesome feedback. But with this data set, what we were able to show is that about 60% of the people reported changes in their gross motor function since childhood. And there was a really small percentage that said they got better, which was really exciting to think about people employing exercises and treatments to help them function better throughout their lifespan. But 27% had reported decline in terms of hand function, and about 9% of the folks reported decline in communication. In terms of functional change by GMFCS level, and again, the gross motor function classification scale puts people in buckets from 1 to 5, where 5 is where you need the most help and are using a power chair, and 1 is when you're walking for most of the day, and 2 you are walking a little bit differently, and 3 you might use some assistive devices. So we could see that there was a difference in across the GMFCS levels, with levels 2 and 3 and 4. So those people that having difficulty walking and those people using assistive devices or wheelchair were more likely to report decline than people on the other end of the ability scale. When we look by age, it was no surprise that this is what we would expect in the general population, but we wouldn't expect such early reports of decline in 18 to 24. But with increases in age, people were more likely to report decline. And that was for gross motor function as well as hand function, excuse me. And we didn't see a relationship of age with communication function. There was not really, you could see that there was a sort of a peak in 45 to 64, but we didn't have enough data to really find anything, I think, that significant. We have a p-value here, but I would be suspicious, but it's looking like there's a trend. Reasons for functional decline are just like Ed had discussed: pain, fatigue, changes in strength or increasing weakness, or changes in your spasticity or your dystonia. And we could see people thinking about things that might have got them better, whether they're changing their lifestyle or their surgery. But there's also a really big impact, like Dr. Hurvitz said, about pain on people's function. So amongst all these 263 people, similar to what we found in other populations, about 78% had chronic pain. And of those people, about 150 answered questions about chronic pain. They were mostly around the age of 28. And that was the average age of pain onset. And you could see, I think that, however, some people had reported they had pain most of their life. And the pain intensity did not vary by GMFCS level or the age group. So that was fairly interesting, that regardless of your level of physical function and your age, people were equally reporting similar levels of pain intensity. In terms of pain interference, when we're looking at, this is an 11-point scale from 0 to 10. So we're looking at around 5, 6, 7 for it to be really high levels of pain interference. And we can see for work and walking, we have some higher, these are medians, and these were about 25% more reported. And then we also see interference, as Dr. Hurvitz talked about, with sleep. Okay. People reported an average number of pain locations as 8, and it ranged as high up to 23, with low back being the most prevalent. And in this sample, it was also then the lower extremities, and that's been found in other larger samples as well. In terms of pain treatment, for the most part, it was either the same or worse than it was a year ago, and pain was not well treated, where 70% of the people said they had less than 50% of pain relief in the last 24 hours. So there's a lot of room for growth there. And if you want to treat the pain, you really need to know the source. And some of the treatments that people did report that helped were physical therapy, over-the-counter medications, massage, exercise, and non-opioid prescription medications. We know that opioids don't treat nociceptive pain, and it is really important to figure out what type of pain you have, because there is individual responses. So moving ahead to pain types and treatment, what is it that we know about pain types and treatment that we could maybe apply to adults with CP and encourage us to do more research? We know that chronic pain is abnormal pain. It's non-protective.
And we also know that it could be either peripheralized or it could be centralized. Chronic pain has been recognized as a disease, and it's a pain that persists for 3 to 6 months, and it outlasts normal tissue healing. There's no physical cause. It's usually non-protective, and the impairment is greater than what would be expected from physical findings. And the treatment should always be multi-professional and interdisciplinary. But when we're talking about types of chronic pain, it's important to delineate or have some sort of idea if you have nociceptive, neuropathic, or nociplastic pain. Nociceptive pain is pain that arises from an actual damage, sort of like an ankle sprain, or when you have really bad arthritis in your leg, or someone who has, rheumatoid arthritis, inflammation, an injury, some sort of irritation. So it's damage to non-neural tissue. Neuropathic pain is when you have a lesion to the nerve, like Dr. Hurvitz was talking about, carpal tunnel syndrome, herpes, post-herpetic neuralgia. You could have diabetic neuropathy. You could have complex regional pain syndrome. So these are when there's a lesion of the somatosensory or the actual nerve. Nociplastic pain is when there's the perception of pain, even when there's not an actual threat. So someone who has centralized pain, if you give them the same pressure as someone who doesn't, the person with nociplastic pain or pain centralization will feel pain with less of a stimulus. So just like we see on the scale, we can see there's more rocks on that one side that's tipping the scale to pain, even though we have the same amount of pressure. The brain is just responding, ouch. And this is really common in low back pain, knee pain, carpal tunnel pain, fibromyalgia, TMJ. So something that could have started out as nociceptive pain or neuropathic can combine with nociplastic as it persists over time. And how you differentiate these pain types is through going to see a physician, physical therapist, combination, multidisciplinary team, getting an examination, seeing the response to treatment. You might also try some nerve tests, and give some people some questionnaires, ask people lots of questions. And this is helpful because it will guide your treatment. Some of the treatments might be pharmacological, and it's beyond the scope of my practice to talk about that. But there's some really nice treatments that they use to look at neuralgic pain. And so you can be talking to your physician about that. But there's a whole slew of non-pharmacological interventions that physical therapists are skilled to provide and have provided to lots of other patients who don't have CP as their primary diagnosis, but may have chronic pain. So one of them is exercise, and exercise targets any type of pain, and it could be any type of exercise. And this has been validated by so many research studies that it's published as what they call a Cochrane Review, which comes out of the Oxford Evidence-Based Medicine Center. And it's a group of experts who review the literature and say, this really works. And for low back pain, this really works, okay? It was going to, yes, and you can have these slides, absolutely. And it can reduce pain as much as education or electrotherapy. It helps with knee arthritis and just increasing your heart rate. So getting in the pool and splashing around gives you some analgesic effect, okay? The next one is one of the most difficult types of pain to treat is the nosplastic pain. When your brain has decided everything is painful and everything hurts no matter what you do. Well, mindfulness is something that is being explored. And in a few systematic reviews of the literature, there's no Cochrane review yet, but there's a large enough body of literature that shows there is an improvement in pain and depression and quality of life, and a large treatment effect for low back pain. It's not clear if it is effective for knee pain, but last February, the research was showing very promising at the last physical therapy meeting. And just to remind you, mindfulness is the basic human ability to be fully present, to be aware of where we are and what we're doing, not to be overly reactive or overwhelmed. And there's lots of ways to practice mindfulness. One of them is just to be still. One is to practice concentrating on your breathing, having gratitude, feeling the sensations in your body, moving intentionally, with linking your movement with breath. And yoga is a whole philosophy and way of life. And it's also one of the most adaptive forms of exercise. And the focus is really on self-love and grounding. So that's a really nice practice. And so is Tai Chi. And it could be adapted to your abilities and done in a chair. But the whole point is visualizing, being still, breathing deep, and linking your movement with your breath. NICPAD, as Paul indicated, we have a relationship with them, but they also have their own wonderful thing where they have all these videos. They have lots of stuff on mindfulness and mini meditations. And loveyourbrain.com has a whole yoga channel that's adapted for people with different abilities. Biophysical agents like hot packs and cold packs, hot tubs are really good for nociplastic and nociceptive pain. Massage, TENS, and dry needling, which is akin to acupuncture, but slightly different. And it's showed really big effects with pain management for people with low back pain. There's probably a Cochrane review on that, but I didn't look that up. The other thing that I want to remind everybody that has physical therapy and all the therapists that are neurotherapists, that maintenance therapy is approved by Medicare. And we are able to delineate the difference between restorative therapy and skilled maintenance therapy. And some people need episodic maintenance therapy to sustain their current level of function or prevent a loss of function. And I think this is 100% applicable to adults with cerebral palsy. So if somebody wants more information on that, I have a fact sheet to share with you for your therapist, and it's available at the APTA website. The other thing is to reduce biomechanical stresses. And I know that's really hard for people with CP because that's the way they can move. But sometimes you have to accept the facts of life and maybe think about like, well, I need to just change the way I'm moving because it's really hurting my knees. Maybe I can't carry my briefcase anymore. Like Jodi said, she's using the scooter. Maybe you need to think about energy conservation, and I direct people to the MS website for wonderful information on energy conservation. And exercise purposely for your heart and your muscles, and move kindly for your body. We are connected with NICPAD Mentor, which is a mindfulness exercise and nutrition to optimize resilience program, which will help train you in an 8-week period and at 4 times a week on these wonderful exercises that are individualized, nutrition programs, and mindfulness. And now I'm going to turn it over to Jodi.
Sorry, my computer, the update thing just came on, so if I randomly leave, I apologize. So I'm not gonna go through all the slides because, like I said, Paul had a good summary of everything. But I just wanted to let you all know why I think participating in research is important and why you should take the surveys on the MyCP website if you haven't already. So I work in research all day, every day. It's basically my life. And I've been doing this for about 12 years now, and I've heard a variety of different things. People don't care about adults with cerebral palsy. They just care about the cute little kids, and that's all they want to make better. Or I have no one to talk to because no one can relate to my situation. And I just really want to talk to somebody. So I do a lot of interviewing of people with cerebral palsy with the different topics that I research. And one of the things, a couple things I've noticed. One is participating in research helps people psychologically process kind of that mindfulness Dr. Gannotti was talking about, to process their situation, go over events, think about events, think about how this fits into their daily lives, because I know when people are going through their life, this is just like, hey, this is cerebral palsy. This is just what I have to deal with. But really looking at things like these surveys, at least for me, really make me think and be able to express myself. Also, people have told me there's not information out there. Well, if you have a chance to participate, it's good to be able to tell your story, get it out there, making sure people know what it is exactly to be a person with cerebral palsy. And for most people that I talk to, being able just to discuss everything that's going on in their lives, being able to give the information gives them a sense of, oh, I did something good today. I'm giving back to others who maybe don't have the access or the ability to give their own information. So it's a way of just letting people know, hey, this is what we go through, this is what we need to do. And I thank you all for listening to us tonight. Do we have time for questions?
I think we do, but that's really up to you. And I mean, we're definitely just at the top of the hour, but I know we had some technical difficulties. And so if you and Dr. Gannotti and Dr. Hurvitz can stay on for a bit, we have a question queued up by Amber. And if you can stop your screen share, we can see people that want to go on camera to ask questions. So just let me just confirm to Dr. Hurvitz and Dr. Gannotti, and you, Jodi, are you able to stick around for a little bit so we can let people ask some questions?
Yeah,
A little bit.
by bedtime, but I'm here. I'm
Okay,
ready
appreciate
to go.
it. Okay, Amber, go ahead. Amber, if you're speaking, you're on mute.
Sorry. So I was just wondering if better positioning and more everyday activities, inclusion when you're younger would be helpful for when you're an adult, meaning not just therapy, but you know, just regular kid activities that not everybody from the older generations got to participate in. And also, I mean, to me, it seems like, I mean, I know we can't prevent all of the pain issues because of the different patterns of how people walk and use their body and compensate. But I feel like if therapists are more mindful or aware of different things, and then how we're integrated into just everyday social activities and physical activities within the community when we're younger, I think that would make a big difference in adults with CP. And then the second part of that is the pain types the same in the non-CP population? I'd be curious to know that as well, because I think that would speak a lot to the first part of my question, or observation, or statement, not really a question.
So I'm sorry if I misrepresented the pain classifications. Those classifications are from the International Association. Wait, am I still muted?
You're not.
No,
you're
we can
good.
hear you, Mary.
Oh, you can hear me? Okay. Those are from the International Association of for the study of pain for all people.
Okay.
And I think that there'd be nothing that Dr. Hurvitz, myself, and I see Dr. Thorpe is on the call. It is for all kids with CP to be treated as athletes and have them work out really super hard to maximize their musculoskeletal, heart, renal system and development. Absolutely. So more participation, more inclusion, not, you know, treating the kids like athletes. Dr. Thorpe and I have a paper about that for Bones.
Can I add something, please?
Sure.
This is both a personal thing and a University of Michigan / other university plug. So I was not included in gyms to do physical therapy, and I always, and I also did adaptive sports though, but I always thought that not being included in gym class kind of set me up for not wanting to do physical activity as much, because I wasn't in it, I wasn't involved, I just did what I did. But the University of Michigan, the University of Cincinnati, Auburn University, UCLA, there's a whole bunch of other universities are coming together to do a collective adaptive sports programs and research, and it is being not led, but I would say coordinated by University of Michigan adaptive sports program. It's led by Dr. Femi Okanami. He doesn't have cerebral palsy, but he has a spinal cord injury, and he's trying to get people more active and motivated in sports and different things like that in the community. So there are resources out there. They're coming up slowly but surely, but there is a coordination trying to go on to include people.
And then what about positioning? Because I think that's so key too, and it's not looked at until there's a problem.
Dr. Hurvitz, can you comment on that?
Oh, Mary, I thought Mary would say something about positioning. You know, depending on the person's spasticity, their ambulation, propensity for contractures, positioning can be very, very important. So I think that's it's certainly something to consider.
Absolutely. I'm sorry. I was struggling trying to find the unmute button.
Okay, any other questions?
Paul, I'm going to just address a couple of things in the chat. There's a question
Yeah,
here.
go
There's
ahead.
studies on neuropathy and non-diabetic and cerebral palsy. No, I haven't searched through all the literature for this topic, but I read a lot of the literature, and I'm pretty sure no one's looked directly at neuropathy and cerebral palsy. And for some of the reasons that we've discussed, higher risk of diabetes, higher risk for pinched nerves in certain areas, high risk for kidney problems. It'd be interesting to know more about neuropathy, cerebral palsy, and how it affects overall function. There's a question from Chris. Lately, I've noticed when I've fallen down and have a lot of trouble getting up, since I've not been able to get my quote strong leg close quote to get to a base. If there's some way to improve that, and I would say that you have to look at directly which muscles are involved and think about how we can strengthen those muscles. A lot of times when we do strengthening exercises, there's certain muscles we need to strengthen. We don't necessarily get to those muscles. If Chris, this is something you used to be able to do, then there's some muscle weakness that's occurred. Probably, has something to do with you're not 12 anymore. How old you are, but probably not 12 anymore. And as you get a little older, sometimes some of those muscles get weaker, as I was talking about. So one way is to strengthen some of the muscles. The other way is to figure out a way to compensate. So that's what I see in the chat.
Someone said looking for a neuro PT that specializes in CP. I would just look for a neuro PT, and they should be able to treat you in terms of doing the same exercises. They just need to know your particulars. And I'm always here to happy to educate physical therapists and talk to them. No
I see a
problem.
question in the chat says, is there any research on the balance of CP people getting worse as they age?
Yes.
The answer directly on that topic, Mary, I wasn't aware. So I just wanted to say that there's a lot of research on the balance of all human beings getting worse as they age. And there's no reason to think it'd be any better in cerebral palsy, and plenty of reason to think it'd be more complicated. So,
And in fact, one of our researchers, Dr. Liz Boyer from Gillette, has been doing a lot of work. I think we've done one webinar on the consequences of falls, which is a lot about the sort of balance and fall risk and things like that. So there's definitely more to be done there.
So I do need to leave now, so I want to thank everybody for their attention.
Thank you,
Mary,
Doctor.
Jodi, if you want to continue, that'd be great.
Yeah, we'll continue for a few more minutes and then we'll wrap up. Thank you very much, Dr. Hurvitz. Mary, maybe you can address this. As there, Paul, I wonder if that's Paul Staunches, but Paul S. said, as we get older, any guidance for balancing exercise, or taking more assistance?
I think that everybody like Dr. Hurvitz said, everybody needs to practice their balance. And the thing is sometimes what happens is if the spasticity increases, still doesn't mean you shouldn't practice your balance, but maybe you should get an assistive device. And that's why it's really good to go see a physical therapist every year, just like for a tune-up, to see what is going on with your balance and look for recommendations for exercises. And I would see anybody that treats stroke or head injury.
Can I add something real quickly? I know for some people that the transition to using assistive devices can be difficult. Some people adapt really quickly, others do not. My advice is, I know it may be difficult and you may not be ready. Don't feel pressured to use the device. If you're not ready, it can be slowly done, and conversations can occur multiple times. So it doesn't have to be a one and done conversation. It can progress, and you are in control of your decision making.
And it could be
Yes.
different environments use different devices. You
Mhm.
know, I have one woman that I'm friends with that she uses the walker, sometimes the cane, sometimes nothing, sometimes.
Mhm.
So
And go ahead. There was a
I'm gonna just comment. So Lauren, I know you've got a question. There's a couple questions from Muriel about different things. And I just encourage you to post on MyCP and I can tag various physicians and whatnot to comment. But Lauren, do you want to ask your question? And we might need to wrap up.
Yeah, sure. So we saw or had a slide that like exercise is good for pain. As everybody else, as I've gotten older, I've gotten a lot more, especially back pain. And I was telling Dr. Thorpe, I actually just started the aquatic therapy. But does the research say anything about what types of exercise might be like, I don't know, it's different for every patient, but like what might be best besides like all exercise is good for pain?
No, I mean, just so what for low back pain,
Yeah.
the largest study that's been done using practice-based evidence had, yoga was the most effective, but that was only 48% people reported better. It's
Yoga.
so
Okay.
variable. It was yoga, and then other people it was exercise. So I think then that's why it comes down to you knowing your body and finding a therapist or a body worker who helps you figure out what type of movement it is. Certainly aquatic therapy is fantastic
Can I
because
jump in here a minute, Mary? This is Debbie.
go right ahead.
I was just gonna say that, I had an adult orthopedic practice as well as my neurological practice, and I treated a lot of low back pain in the water. And I would have people coming to me 10 out of 10 pain. By the end of a 45-minute session, they were down to 0. So for low back pain or any kind of back pain, the water is wonderful just because of the special properties of the water that reduce the weight on the spine.
Okay. Well, that's great to know. I've only been doing the aquatic therapy, probably only had about 5 sessions. So, yeah, and swimming is difficult just because of the coordination aspect, but there's probably a
Right.
lot more I could do than that.
No, you can do yoga poses in the water to open up your spine. You can do all kinds of, find somebody that, you have in your, anyways.
Okay. No, thank you. No, this was
Okay,
great.
I think we've kind of gone a little bit beyond the limit. I know it's I'm on the West Coast and the sun is shining hard, but I know the sun is probably set there on the East Coast, so I see some yawns and whatnot. So I'm gonna let everyone go. Thanks everyone for your time. Thank you, Dr. Hurvitz, who's gone, Dr. Gannotti, Jodi. Thank you so much for putting this presentation together and being available to answer questions, and everybody for tuning in. Again, if you join MyCP, there's and you post questions, if they're sort of clinical questions and whatnot, or evidence-based questions, we tag people and get them to answer if they can. Dr. Janai has been a great help there. So thank you, everybody. And we'll see if we can attach the slides to the note about the recording that comes out. So
Yeah,
thank you all.
sure, no problem.
Good night. Have a good
Good
evening.
night. Bye.